The goal of tonight's training is to teach you all to be effective, active bystanders, especially in high threat events such as shootings, for example. This collection of information that we cover in the skills, can help keep people alive until help arrives. That's the idea. So this slide provides an overview of the training. We're going to start about the critical role played, talking about the critical role played by active bystanders in emergencies, including some case studies. Then we're going to preview the 4 preventable causes of death that everyone can learn to recognize and treat to keep people alive until help arrives. Then we will talk about how our brains tend to work in disasters and how awareness of that can help everyone respond better. And finally, the bulk of the presentation is kind of a deep dive into those 4 key steps to being an effective bystander, which we call the 4 R's. Recognize what's happening, respond quickly and decisively, rescue yourself and others, including emergency first aid, and that's where most of the time will be. And then report what you know to 911. So we also refer to these 4 R's as the emergency response arc. So let's start with the critical role played by active bystanders. This photo was taken shortly after the shooting at the Harvest Music Festival in Las Vegas in 2017, which killed 60 people. And what I want you to do is just look at what do you see here in the moments after the shooting. It's very chaotic. So there's lots of people running around. A lot of them are helping people. There's family, there's friends and strangers helping each other. So what happened is people realized what was going on. They moved themselves and others to safety. They initiated first aid and they gave comfort to the injured, and they called 911 with information. So these are the 4 R's. So everyone kind of does these things naturally. But what we want to do is talk about how to do them more effectively and more quickly. So what you don't see in this picture is any first responders because they just haven't had time to arrive yet. So the point is that the active bystanders are always the first on the scene and the first to offer help to others. So it really pays for everyone to learn the skills that we're teaching tonight. So we're going to talk a lot about active shooting events, because they've become more common and more deadly over the last few decades. We want everyone to know how to react effectively. And as we've seen this year, of course, they're unfortunately continuing to happen. As this slide points out, active shooting events occur frequently, and they happen everywhere that people gather. So schools, churches, workplaces, concerts, retail establishments. An important thing to know is that they tend to begin suddenly and end quickly. Most last less than 10 minutes. There are some exceptions, such as the Boulder grocery store shooting this year that went on for almost an hour, but most end quickly. A few cases around the capital region that you may remember are the Virginia Beach Municipal Center in 2019, Capital Gazette newspaper in Annapolis in 2018, the Congressional baseball game in Alexandria in 2017, the Navy Yard in DC in 2013, just some local examples. So for more information on active shootings, you can check out the Secret Service National Threat Assessment Center, and Janine will post the link to that in the chat. So from a public health perspective, the rise in shootings, especially with more deadly weapons like high velocity rifles, has meant that the injuries typically seen on the battlefield have become more common in civilian settings. So as a result, the medical and public health response to shootings has evolved over time. Military doctors learned a lot about effective treatment of battlefield injuries from the wars in Afghanistan and Iraq. What we are teaching tonight is based on Tactical Emergency Casualty Care, TECC, which is a protocol that adapts the lessons learned from the military to a civilian context. So Dr. Reed Smith, who created tonight's course, is one of the leaders in this effort. A key learning, really the biggest single idea that we want you to take away from tonight's training, is that the research has identified 4 specific causes of death that can potentially be prevented with rapid treatment by any bystander. And that's what we're going to go over in detail tonight. You may have heard of a similar effort called Stop the Bleed, which is a national campaign to encourage bystanders to help in a bleeding emergency. So tonight's class is a Stop the Bleed class. It covers those guidelines, and in fact goes beyond them because it also covers things in addition to bleeding. So this slide shows what these 4 preventable deaths are. This is the bottom line from the research on military deaths. Massive bleeding from limbs, airway obstructions, penetrating chest wounds, hypothermia, and shock. These obviously aren't all the causes of death in mass casualty events. They're not even the most common necessarily, but they're just the ones that everyone could do something about as a bystander. And they're listed there in order of how quickly they can kill. And so it's the order in which we discuss them and the order in which we should treat them. So we're just going to preview them now and talk more about them in more detail later. We're going to start with just a picture of each of the 4. And here's a warning that there's going to be some graphic pictures of severe injuries in some of these slides. And the reason that we're showing these is not to be shocking or upsetting or gratuitous, but to illustrate the key points that we're talking about. So seeing the pictures will help you understand the injuries and the scenarios and be prepared to be an effective active bystander. We're always going to try to give a warning so you could prepare yourself or look away if you'd rather. So the first one is a graphic image of severe bleeding. This is a frame grab from a video of an amateur bullfight in Nicaragua. The bull gored the man's right arm, injuring a major blood vessel, maybe the brachial vein by the way it looks. Blood is pouring out in a steady stream, and it needs to be stopped to save this man's life. So at this rate, he could bleed out in a few minutes. In this case, what happened was bystanders were able to apply direct pressure and improvise tourniquets until paramedics arrived and the man survived. Severe bleeding from arms and legs and junctional areas where they attach is the fastest preventable cause of death and is why it should be treated first. So we're going to go through that in detail, but the important thing for now is just to recognize it as being first on the list. Another graphic image. This one is airway obstruction. It's the second fastest cause of death that is preventable by bystanders. The key to this one is just knowing about it because it may not be visible or obvious if you're not aware of it. So in this image, someone's unconscious, lying on her back on the floor. There's some drool that might suggest it could be an overdose or some type of poisoning. So the point here is an unconscious person should never be left on their back because the tongue can slide back and block the airway, or vomit, blood, or other fluids can pool and block the airway. So, we're going to talk about how to treat this. The short version is you roll them over onto their side. And you should also do this for somebody if you see someone passed out drunk, for example. Okay, another graphic image. Penetrating chest injury is third on the list because it's the third fastest preventable death and should be treated after severe bleeding and airway obstruction. So this picture shows a bullet wound in the chest. Notice that it is not bleeding profusely. But it's still potentially deadly because the hole in the chest wall can compromise the mechanics of breathing due to a buildup of air in the chest. This is called a pneumothorax, air in the chest. These injuries are very common in shootings, and rapid treatment can potentially help keep someone alive until help arrives. We're going to talk about this one in detail later, but the short version is to cover the whole. The fourth fastest preventable cause of death may not be obvious, and it's hypothermia and shock. In trauma, the body, it may not be able to maintain a stable temperature, especially if someone is wet or lying on cold ground. Hypothermia occurs in about 2/3 of trauma patients, the research shows, and it's much more fatal for trauma patients than for non-trauma patients. There's basically 100% death rate in trauma patients whose core temperature falls below 90 degrees, compared to only a 20% death rate for non-trauma patients. This picture is an exercise from the UK, and you can see that rescuers are keeping the victims on stretchers off the ground and using mylar blankets to help keep them warm. But it looks like they might even do more to cover up some exposed skin there. To prevent hypothermia, you need to get patients out of wet clothes, off of cold floors, and under blankets or coats. It's easier to prevent hypothermia and shock than to treat it, so you need to be aware of this and take action to head it off. So those are the 4 pictures for now, and we're going to move on to a case study. This is a case study illustrating these 4 preventable causes of death. What happened in this case study, Dr. Smith and 2 other doctors looked at the autopsy reports from the Pulse nightclub shooting in Orlando in 2016. And what they did is each of the doctors independently determined which deaths they thought could have been prevented if the patients had received first aid within 10 minutes and hospital care within 1 hour. And their conclusion was 16 out of 49 deaths were potentially preventable under that definition. So that's about a third of the deaths. And of those, 10 involve the injuries that we just discussed, which could be treated by active bystanders. So bleeding, airway, and pneumothorax in this case. The rest were injuries that were treatable with rapid removal to a hospital. So the bottom line is learning these skills really can help save lives. So now we're going to start talking about teaching some skills that you can use to be an effective active bystander. This is on the next slide. So these skills are useful for both major emergencies and smaller everyday emergencies. So we're talking about mentally rehearsing and box breathing. Will help you stay calm and react quickly and make better decisions under stress. Douglas will talk about run, hide, fight, which covers the main options you have in an active attack environment and how to make best use of your options. We're going to talk about techniques for effectively moving injured people to help get them out of harm's way so you can provide first aid. And then we're going to spend most of the time talking about how to treat the 4 preventable causes of death. And finally, we're going to emphasize the importance of providing psychological support and kind of human connection to injured people. Because sometimes that's the best thing you could do, is to hold someone's hand and stay with them, get them to fight to stay alive for their loved ones, and reassure them that they could get through this situation. It might be exactly what they need at that time. So let's start by learning a little bit about how our brains tend to work in disasters and how awareness of that can make us more effective responders. Amanda Ripley is a journalist who studies human behavior in actual disasters. She interviewed a lot of survivors and witnesses for her book called The Unthinkable, which describes what she learned and how we can all apply those lessons to react more effectively in emergencies. She found that people have different reactions to emergencies, not surprisingly, but often we don't react how we think we will. And she identified 3 stages that people tend to move through, which they didn't necessarily expect. And we're going to cover those 3 phases on the next slide. She calls the 3 phases the survival arc, and awareness of it will help you move through these stages more effectively. So the 3 stages are denial, deliberation, and decisive moment. And the idea is you want to move through those first 2 as quickly as you can. Denial is the brain's tendency to not immediately recognize an emergency for what it is. And the reason is that our brains take shortcuts all the time to be more efficient. And one shortcut is to assume that the current situation will follow past patterns. This is called normalcy bias, and it usually serves us quite well. But it could be a problem if you're too wedded to it. So just an example of this is, very common after shooting to hear a witness say, "I thought it was firecrackers," because people aren't used to hearing gunshots. Most people aren't. In the deliberation phase, you recognize the problem, but you don't know what to do about it. So this is where fear kicks in, which can be really debilitating. Sometimes people just freeze, very common to just freeze. Sometimes they mill about looking for more information or methodically gathering things. Often people look to others to talk to compare info and discuss and debate. And the problem is all that can take a lot more time than you actually have to escape. So the final stage is when you decide to take action, and doing that also helps other people take action. Awareness of these stages can help you move through them more quickly. And that's why we're talking about them. Okay, next slide is a particularly graphic image, or it's a graphic image, and we're going to talk about a case study. This is the Beverly Hills Supper Club, a fire in Kentucky in 1977, and it's a major example of how the time it takes to move through the survival arc can be deadly. So there are 165 people who died, over 200 injured in this event. Now, the major reason for such a high death count was the lack of smoke detectors and sprinklers and fire alarms, and a small number of accessible exits. Things that we take for granted now were not as common then. But the point is that meant that people didn't have enough time to work through their survival arc. An example is one person who did was Walter Bailey, who was an 18-year-old busboy at the restaurant. When he saw smoke, he immediately led people out to safety. And then he went into a large ballroom and grabbed the microphone out of the hand of a comedian and told everyone there was a fire and that they should get out. He pointed out where the exits were, and then he walked out. But a lot of people didn't follow him out. Maybe they didn't really know what to make of this, or they were waiting to hear some more information or confirmation. But very soon after he left, heavy smoke started pouring into that room, and it quickly became impossible for everyone to get out. So responders found 130 bodies piled up at the doors trying to get out, and some were still sitting at their tables. So studies have shown that people are less likely to take immediate action if there are other people around watching them. So it's something that you should be aware of, and it's critical that you need to be able to kind of break through that tendency, because the time it takes to decide what to do can be more time than you have. Okay, the next slide contains a particularly graphic image. This is the Boston Marathon bombing in 2013, another case study where moving quickly through the survival arc helped save lives. 3 people were killed by these bombs, 264 injured, with at least 14 facing traumatic or surgical amputations as a result. There's a major event. Obviously, the Boston Marathon was a major event, so there was already a lot of first responders on the scene. But even so, the high number of casualties and the severe injuries exceeded the capacity of the professionals to respond immediately to everyone. So bystanders jumped in. Another complicating factor in a case like this was people dropped their bags when they fled, and because the bombs were in bags, every bag had to be treated as a potential bomb. So that made a quick bystander response even more important. So an example here, the case study is the man in the cowboy hat, Carlos Arredondo. What he did was he very quickly realized what was happening. He saw the critically injured Jeff Bauman there in the picture, who he managed to pull into a nearby wheelchair and started wheeling him towards the ambulance to get him help. And Bauman survived and later helped ID one of the bombers. So what can we do to speed our movement through the survival arc? So just being aware of all this is a really great first step. But the thing that really makes the biggest difference is practicing it, the mental rehearsing. The quote from Amanda Ripley, the best way to get the brain to perform under extreme stress is to repeatedly run it through rehearsal beforehand. And the reason that repeatedly practicing something works is that it literally strengthens the neural networks in your brain, so that each time you do it, it gets a little faster and a little easier. And the goal is to be able to do things without thinking, which is what people mean by muscle memory. So an example is repeatedly rehearsing things like identifying all your exits in a room, or what would you do in a case of a fire or a shooting or a tornado or an earthquake or something like that. It's important to do this practicing because trying to figure it out in real time is going to be really hard under extreme stress. So another thing that's helpful to know in advance is what could be going on in your brain and body under extreme stress. And often it's not, it doesn't give you the chance to do the things that you think you will. So what's actually happening is your heart and breathing rates increase. I think everyone probably expects that. Adrenaline is released, blood is shunted to the muscles to help run or fight. Endorphins are often released, which reduce pain. Also, various senses can be either sharpened or blunted depending on what your brain decides it needs in the moment. So you may experience tunnel vision. Time may seem to slow down. So while some of these kind of may seem like gaining abilities, that you also lose some abilities. Typically, fine motor control decreases, complex reasoning declines. These are normal and natural, almost universal responses. So understanding these, they're involuntary. And so understanding that this could happen is going to help you get through it faster. So this next slide plots how these changes relate to heart rate, just as an example. So the optimal range for taking emergency physical action is the orange range there towards the bottom. At heart rates above that, the skills begin to deteriorate and put you in greater danger. So unfortunately, we can't directly control heart rate to keep them in the orange zone. But there is one thing that we can control that will affect heart rate. And if you're wondering what it is, I'll give you a hint. It's talked about in every yoga or meditation class. And it's this is a point where we would ask people to chime in and guess, but in the interest of time, I'm just going to tell you, you probably already have guessed the answer. It's breathing. So you can control your breathing, even though you can't control your heart rate. And when you control your breathing, you can slow your heart rate. On the next slide, we will talk about box breathing, which is a great way to do this. So box breathing is a simple technique. It's widely used in fire and EMS training and law enforcement and military to control breathing and regulate heart rate in order to stay calm and focused during stressful events. So the way to do box breathing is you breathe in through your nose for a count of 4, and then you hold it for a count of 4, and then you breathe out for a count of 4, and then you hold it for a count of 4. And then you can just repeat that as much as you need to calm down a little bit. It's an important skill, and it's also useful in everyday life. Let's practice it. I'm going to count it out loud a couple times and want everyone to kind of practice doing this. So I'm going to do it like this. I'm going to count it in. So you breathe in, 2, 3, 4, hold, 2, 3, 4, breathe out, 2, 3, 4, hold, 2, 3, 4, breathe in, 2, 3, 4, hold, 2, 3, 4, breathe out, 2, 3, 4, hold, 2, 3, 4. So I recommend practicing that and do it a little slower than I was doing it there. And you could use that to help in all kinds of situations in life. Okay, so these are all kind of important ideas that can help save your life and others in emergency. So we want to make sure everyone kind of has this down. We're talking about kind of autonomic responses that will affect you in an emergency so that you can be prepared for them. And understanding the survival arc, practicing repeatedly, box breathing are all these skills that will help out in kind of any emergency, not just a severe one that we're talking about. I'm going quickly because we have a lot to cover, but please, if anyone has any questions about any of the things that we're talking about, go ahead and post them in chat, and Janine can help answer them, or we could cover them. Okay, so now we're going to shift gears and start to work through these 4 R's. We're going to start with recognizing situations, which always seems easy after the fact, but it's not so obvious in the moment necessarily. So I'm going to start with a video. This is our first video. This one challenges you to pay attention to specific actions to see what you recognize. And as a reminder, if your video freezes, logging out and back in sometimes will help.
This is an awareness test. How many passes does the team in white make? The answer is 13. But did you see the moonwalking bear?
So how many people saw the moonwalking bear? You can go ahead and type yes or no in your chat if you did. Don't be discouraged if you didn't see it. I certainly didn't see it the first time. The point of this exercise is that it's normal for our brains to tune out what's going on in the background. In fact, it's actually really important that our brains do that for us, or we'd always be overwhelmed with data. But we do need to recognize the implications of that. And sometimes you need to be aware of things that aren't immediately obvious. So we're going to talk about situational awareness. In some ways you can use your senses to recognize a threat. You may also want to visit some online sources for identifying signs of threats that brew over time, like in a work or a school or a social context. 2 good ones are the Secret Service National Threat Assessment Center that we already mentioned. And another one is called sandyhookpromise.org. Janine can post the links to those in the chat, and anyone who's interested can follow up to check them out. Okay, here's another nightclub fire as another case study. So you may remember this one happened in Rhode Island in 2003. We use this to illustrate the connection between recognizing a threat and responding quickly. In this case, the fire started when a pyrotechnic display on stage ignited acoustic foam. It's shown on the right in the picture. And afterwards, survivors said that at first people didn't recognize it as a serious threat because they thought the flames were just part of the show. A thing that is really important for everyone to understand is that in a fire, the main event is usually the smoke, which quickly reduces the visibility to zero. It blocks out the exit signs. It will probably make your eyes squeeze shut involuntarily, and it is toxic and will kill you quickly. So finding a way out of a crowded space under those conditions is extremely difficult if you haven't thought about it in advance and you don't have any plan. In this fire, the only exit most people knew was the way they came in. The orange circles at the front there by the entrance showed where 31 bodies were found piled up in the hallway near the entrance, trying to get in, trying to get out. And the real tragedy is that other exits were available. There were exits available through the kitchen and the bar to the left in the picture. There was a stage exit to the right, and there was some exits in the back as well. So this is a grim example of what can happen when people don't quickly recognize the threat and only know one way out. So it's super important for you and your loved ones for the rest of your lives, wherever you are, always identify multiple exits. So this wraps up the first R, which is recognize. In an emergency, you want to recognize what's occurring, maintain awareness, and react quickly and effectively. You need to use all your senses. You need to, see things like smoke, fire, people running, power lines or attackers. You need, do you smell things like gunpowder or smoke or oil or fuel? Do you hear things? You want to take in all this feedback and try and kind of integrate it into some kind of story that tells you which way to run relative to the dangers. The second R is respond, and it's respond according to your plans. So that's kind of a key part, is the second part, according to your plans, because your response will be much faster if you have a plan that you have already mentally rehearsed. Otherwise, there's just a really high risk of kind of sitting still, frozen with indecision, or trying to figure out what to do, which can be deadly. In her book, Amanda Ripley, points out as an example here that the standard safety briefing in an airplane always says secure your own oxygen mask first before assisting others. It doesn't typically explain why. And the reason why is that in the event of a sudden total decompression at 30,000 feet, you might only have 10 or 15 seconds to get a mask on before losing consciousness. And so the point is you need to have a plan so that you can react quickly enough, even if it's just like if the mask comes down, you put it on without thinking about it. Then you look around and see if you can figure out what's going on. In a building, again, it could be looking for the exits. It could be if I see smoke or fire over there, then I'm going out on this other side, something like that. Simple plan can make all the difference. So again, first thing is identifying exits at regular places like work. A good tip is practice using all the exits and staircases, not just the ones you normally use. So often many of us are creatures of habit and just always use the same way in and out, but look for the alternatives as well. And in restaurants and coffee shops and clubs, look for things in the back. A practice that Dr. Smith recommends at work is what he calls Exit Route Tuesdays, which is the idea that every Tuesday you take a different way out than you normally do. You find all the unusual exits, or you do a complicated series where you go down one floor and then exit differently from that floor. The idea is to be able to be familiar with all the ways out so that you don't have to figure it out in real time in an actual emergency. Another thing you could do is kind of make a rally point if you're with family or friends, a place to meet up. If you get separated, it only takes a few seconds. It could be really helpful. And you can do this out loud in public. You can model this behavior by saying things like, hey, I see exits there and there. If we get separated, we'll meet back at the car. So I'm about to turn it over now to Douglas, and he's going to talk about run, hide, fight. Douglas, you can take it from here.
Good to go. Thank you, sir. The important thing about run is have a plan for doing it. It's a great option if you have quick access to an escape route, but take a second to plan a route, even if it has to be somebody else who you're with that knows the building. If you don't know the building at all, remember where exit signs lead to. If they don't lead you toward the gunfire, then it's a valid routing. Use your exit signs. Help others if you can, but do not let their freezing freeze you. Lead by example and say, follow me, let's get out of here. Don't run around corners as you're leaving. Look first around the corner, otherwise you can be leading everyone into danger rather than out of it. And when you do exit, when you get out, exit with your hands empty and raised. They don't know who you are, the police, as you leave. Keep running till you're clear of the danger, clear of the building, or until you're told to stop. And when you encounter first responders, continue to keep your hands raised and empty. Their protocol, of course, is to corral everyone and then identify everyone under watch. Don't take it personally. The option to hide, if running is not practical or if running is interrupted, is another valid choice in run, hide, fight. It means much more than duck under a desk. You want to lock the doors, barricade them with furniture and boxes. Remember, Xerox paper, like water, weighs 64 pounds the cubic foot and is bulletproof. Bind door closure mechanism, the handles in the upper right there, with a belt or a purse strap to keep delay the door opening. Line up along a wall out of sight, and also to avoid shots being fired through the glass or through a door. Turn off the lights, mute your phones, and have in hand anything that you might use as a weapon, because your next option may perforce be fight. When it's down to it, when we're looking at fighting, you've got to commit to your survival. Attack immediately, decisively, and violently. Use any weapon at hand, heaviest, longest, or sharpest, that strikes you as usable. Exploit the element of surprise, or else that surprise evaporates as your way to gain the upper hand. Attack viciously, go for the eyes, the throat, the groin, and be ready to exploit any firearms that jam or any need to reload. That's a pause on the other guy's part. Fight until you are sure the threat is neutralized. Take this very seriously. And then check whether that was the sole threat. Then reassess, are you going to continue to hide, find another place to hide, or are you going to run? Please, if you would, post on the chat any questions you have about run, hide, fight. We'll get to them. When rescue, when the moment to rescue arrives in the 4 Rs, after we recognized and responded to the situation, we rescue the injured. We take definitive action toward ensuring your and the other person's safety. Rapidly evacuate the injured to safety. You need to move yourself out of danger or you can't help anyone. So in considering, keep considering changes in the situation and be ready to move again if you must. Next, we'll look at how to move injured people. When you must move someone, move to an injured person to safety, find ways to do it that can be practical and give you leverage. It's encourage other people to help you and then roll, drag, or carry the injured. Anything with wheels is good, rapid, handy transport. Anything by way of a curtain or a blanket, a coat, a rug, can be used to drag someone to reduce the friction and to give you a better handhold on the person. At the head end, a broken down box, large cardboard surfaces, or use one person drag or two person carry, which we'll look at next.
Okay, so these pictures show a one-person drag on the left, two-person carry on the right. And these are fast and efficient techniques for moving people that are carefully calibrated to use proper body mechanics. So we're going to show some videos next about how this works, but I just want to point out some key concepts to focus on when you watch the videos. First, the rescuer standing behind the patient is doing the same thing in both cases. They're pressing the patient tightly up against their own body. They're crossing the patient's arms, and they're reaching under their arms and gripping the opposite wrists so that the right wrist is in your left hand and vice versa. And that is going to help keep a good grip for lifting. They're also keeping their back straight when standing so they don't throw their backs out. In the one-person drag, you note a nice rhetorical flourish. The rescuer has crossed the patient's feet, and that helps reduce drag. I would say that's great if you have time to do it. If you don't, then don't worry about it personally. But I think it's a great idea. In the two-person carry, the front rescuer is lifting the patient under the knees, not the ankle. So that's absolutely crucial for good body mechanics. If that rescuer were lifting under the ankles instead of the knees, then the body would sag down in the middle, be much harder to carry properly. So these techniques will minimize your effort and allow you to move someone through doorways and hallways. The next couple of videos illustrate how these work.
So first thing I want to do, right, is close his legs and cross them. Because when I'm dragging him, I don't want 2 points of friction. I want 1 point of friction. It's going to make it easier on me. Next thing I'm going to do is cross the arms. Now, at this point, I'm a little winded, all right, as you should be because your adrenaline's going. So just take a second, prop them up, use your thigh here to keep them propped up, gather your thoughts, take a second to catch your breath. Now I'm going to reach in, under, right? And it's important to note that I'm grabbing, my right hand is grabbing his left wrist. My left hand is grabbing his right wrist. Very, very important that you grab the opposite wrists. Most of the time, some people, they just want to go like this. They want to grab their own wrist like this, and it slips. With all that weight put on there, your grip will slip right here. Especially once you start sweating, forget about it. So you have the highest chance to keep the hold by grabbing their wrists. Just like that. Sure. At this point, I'm now going to situate myself, proper body mechanics, right? Keep my back straight because I don't want to throw my back out. My legs straight up. Now at this point, I can drag him.
Okay, on 3, lean him up. 1, 2, 3. Okay, again. On 3, stand him up. 1, 2, 3.
So these are the key concepts for effectively moving injured people. And so I just want to summarize them quickly and make sure everyone has these ideas. And it's great to practice these if you get a chance. So remember, you want to start low and close to the patient, and you want to lift with your legs. And you want to hold the weight as close to your own body as possible. The one-person drag, the crossing the legs at the ankle will help reduce friction. And then grabbing the opposite wrists are really the key principle there, and lock their arms to the chest when you lift them up. With a two-person carry, There's a little bit more weight at the head. So if one rescuer is stronger, then maybe they want to be at the head. And then usually the technique is the person at the head is the one who's calling the lift, and the person who's at the feet, or I should say under the knees, is calling the direction as they move through doorways or downstairs or something like that.
We have a mnemonic for treatment order. We treat in SCAB-E priority order because it's listed in terms of the immediacy of the life threat. So always remember, the first step is your situation. Is your situation safe or not? And if it isn't safe, you need to make it safe before you start any kind of treatment. If you're in immediate danger. So an example of immediate danger would be, let's say that you are in an office and you hear shooting and it's obvious that the shooter is present. You're not safe. So you need to move yourself and possibly anybody else that you're trying to help to a safer location. We say commonly that we fight the worst first, and that really goes for situation first. Another example is if you're in a fire, Paul mentioned this, but it bears repeating, the smoke is going to incapacitate you before you're going to get to any other kinds of treatment. So for you to survive, and then for you to help others survive, you're going to have to be ready to move to a safer position. And as Douglas mentioned, this can change. So you might be in a safe spot and you might need to be ready to move. You need to stay adaptable. Before we get into bleeding control, I do want to talk a little bit about some of the things that you might find that can help you. In public areas, a lot of public buildings have TECC kits or bleeding control kits. And these kits have tourniquets, gauze, pressure bandages, ACE bandages, Mylar blankets, all the kinds of things that we're going to talk about tonight here on the program. So you want to look where these items are located when you're not in an emergency. You should be practicing this in everyday life. If your building doesn't have a TECC kit, then you should consider bringing in some things yourself, or at least mentioning it to somebody, and maybe you can get a kit in there. When you're treating the wounded, you're always going to look for these resources. So where do you look? Well, first of all, communicate with others that may be there. Maybe they're more familiar with the building than you are. You'd look in hallways, office areas, cafeterias, gyms, near elevators, basically anywhere where people gather or might ask for information. This is where you can find these kinds of supplies. Get in the habit of looking around for them wherever you work and play and shop, and try to do that during times when you're not under an emergency, so you'll know where they are if you need them. Another thing I want to just touch on, one of the top reasons why people don't jump in as active bystanders is they're afraid that they might get sued, their liabilities. You know, there are other concerns like I've heard that I have to, you know, under certain circumstances, I have to protect the cervical spine. I might cause paralysis. As we have given you the example of the fire, you know, you need to get this person out of a dangerous situation. You can worry about the cervical spine later. If they're in a burning building, the smoke is going to get them before anything else will. So when wounded people need help, don't let common worries and misconceptions slow you down. Treating or moving a person whose life is in danger is better than doing nothing. So they're Good Samaritan laws in all 50 states and the US territories. And these laws protect people who are giving good faith assistance as long as it's within the scope of your training. And we did underline that to make sure you saw it. You need to stay inside your scope of training, not go outside of it. We're not training anyone tonight on how to do a tracheotomy. Even if you watch it on YouTube, it's still outside the scope of this class. Stay within the scope of what you've been trained to do, and go forward as an active bystander. After assessing the safety of the situation, moving the injured to safety as needed, we can start caring for the wounded. So let's get into that. The next step in SCAB-E order is C, and C stands for circulation. So what do we do to address circulation issues? Well, first of all, we're going to need to address any kind of bleeding wounds. Blood carries oxygen to all of our cells, and it takes CO2 away. And this is very important. It maintains a balance that is critical. When we start bleeding, this process slows down. Our body tries to protect us by restricting blood flow to only our essential organs. This is actually also the beginning of shock. If we lose enough blood, even the essential organs won't have enough to keep up, and we can enter a state of irreversible shock and organs start to shut down. How much blood can we really lose? Well, an adult has about 5 or 6 liters, or approximately 5 or 6 quarts. An 80-pound child has about half that. How much can you really lose? An average healthy adult may be able to survive losing about half, as we see in the picture on the slide. How would you tell that you've lost half? It's really, really difficult to tell. And we're going to be talking about that on the next slide. All right, every moment matters with severe blood loss. We know shock is bad. We know uncontrolled bleeding leads to irreversible shock, which is fatal. So how do we decide if it's too much blood and we really need to be worried about it? Well, really, the bottom line is you don't. The best way to look at it is if you have this visceral reaction, meaning you get chills or you get a feeling inside your body that, oh, that's a lot of blood, then treat it like it's serious bleeding. Don't worry so much about if it's spurting. Basically, if blood is flowing, treat it like serious bleeding. Look for how much blood is being lost, not how serious the injury looks. Again, the loss of blood fluid volume is the threat. Focus on heavily bleeding wounds first. Now, I'm going to talk about this more than once, but there is one exception as far as heavily bleeding wounds, and that's an amputation. If a person has an amputation, even if it's not bleeding a lot, you immediately address an amputation with the highest level of bleeding control that you have, preferably a commercial tourniquet. And we're going to talk a little bit more about that in a few more slides. All right, all the blood in your body comes out of your heart and it goes out to your extremities via your blood vessels. When we want to stop life-threatening bleeding, we're going to treat with direct pressure first. I want you to say that in your head for a second. Treat with direct pressure on the bleeding wound first. If you walk away with nothing else tonight about bleeding, and you remember to apply direct pressure to a bleeding wound immediately, then you're halfway there. When we apply direct pressure, we're squeezing the blood vessel closed with our hands or by putting a knee on it. So basically, we're taking the flesh and skin and muscle and the blood vessels inside of all that, and we're compressing it against hard stuff inside, basically our bones. And we're trying to squeeze those blood vessels shut and stop blood from flowing through them. Dr. Reed Smith, Arlington County's medical director, has a great video where he talks to us about direct pressure. And then we're going to talk even more about it after the video. As a reminder, if your video freezes, just log out, log right back in.
Pressure stops bleeding is one of those things in medicine that we've known for a long time. It's one of the things that it's a truth in medicine that's true today, and it'll be true in 100 years. Pressure stops bleeding. So what we really want the citizen to do, how do you stop bleeding if you're on the side of the road or in the middle of the woods and waiting for someone to come help you, is you have to put pressure on the bleeding. There's a couple things about that people need to understand. Number one, you got to understand a little bit about the anatomy. The major blood vessels, the ones that will cause bleeding to the point where you're going to die, are always deep under the skin near the bone. So they're always down, they run right along major bones. That means that you have to apply a lot of pressure. It's not just a little bit of pressure, it is a significant amount of pressure. Number two, it may cause some discomfort, and that's okay. You're not doing any damage, you're not hurting them, you're actually saving them. And number three, you have to hold it for a long time. Right? You have to make sure you're holding pressure for long enough that the clotting process starts. How long is that pressure? As long as you can. Until we get there. So you can't hold it. What people have a tendency to do is they want to come up and put a bandage on the wound. A bandage doesn't stop bleeding. All it does is soak up blood. And again, that blood that it's soaking up into that bandage, it should be in your body. It shouldn't be being soaked into the bandage. We want it to stop. So before you put the bandage on, before you make something look pretty, you want to put pressure on it. That pressure is what works. If you don't get the bleeding stopped, even if you slow the bleeding, maybe you buy that person enough time until we can get there and completely control it. And then some bleeding can't be controlled. The wounds are too big. The artery is too large. The vein is too large. That's when we look at tourniquets. Right? And even still, if you have a wound that needs a tourniquet, I want to put pressure on it while I'm getting the tourniquet in place. Because if you're free-flowing blood while I'm working on getting my tourniquet, you're dying while I'm getting my tourniquet in place. We want to stop the dying. We stop by stopping bleeding with pressure, and then we apply the tourniquet, which then further controls it. That's the key.
Okay, so let's talk a little more about direct pressure. Again, say it in your head. you must immediately apply direct pressure to bleeding wounds. And you can do that in one of two ways. You can apply direct pressure to the wound itself, or you can apply it to an anatomical pressure point. And if you look there in the picture, you can see the circles are around the anatomical pressure points that we use. So if you apply direct pressure to the wound and the bleeding stops, great. Even if the bleeding slows down, you're ahead of the game. Keep holding direct pressure. If bleeding doesn't stop after you've held it, and if it's severe bleeding, it's probably not going to stop just because you're using direct pressure, but you will slow it down. Then you could hold pressure on an anatomical pressure point. So the top circle there is the brachial anatomic pressure point. It's on the inside of the arm, just below the shoulder. And there's also one in the crease between the groin and the upper leg. So if you put pressure there, you can pretty much shut off blood to the extremity. Now the femoral artery runs close to the surface at the top of it. So if you kind of look at the top of your zipper and you move to either side or about midway in the crease, that's where you would put a knee or put your hand and use your body weight to shut down blood. All right. Once you've done that, you can think through other options that you have for bleeding control. And tonight, we're going to go over a couple of them, and I'm going to start with the tourniquet, and later Sue will talk about wound packing. So after direct pressure, got to think about your next steps. Tourniquets used to get a bad rap. Their very first tourniquet was a braided silk rope. It stopped bleeding, but it actually cut into nerves and cut into the flesh, so it caused a lot of damage. At another point, a change was made, and it became sort of a narrow strap. Now that was better, it didn't cause the nerve damage, but there were still some problems with tissue damage. So now we get to modern tourniquets where the strap is actually 1.5 to 2 inches or so, and we seem to have really hit the sweet spot there. We have a lot of data that came from the wars that we fought in Iraq and Afghanistan, and they show that modern tourniquets can stay applied for 2 hours, and in many cases even more. So a lot of us my age and older, we might have been told by our elders, well, you're gonna save a life, but you're gonna lose a limb when you use a tourniquet. And I need you to take that and just discard it into the ash pile of history, because now we know that tourniquets can remain on actually for quite a long time without any harm coming to the limb, and you can save a life. So if you need a tourniquet, don't be afraid to use it. All right, so how do tourniquets work? Let's talk about that. They compress the tissue around the limb. We talked about that already. So everything around the limb, that includes the blood vessels, the flesh, everything is compressed against the bones inside, and we're trying to stop the blood flow. And then what is a tourniquet? We talked about the strap. It's a strap. It's at least 1.5 inches wide. It's also a buckle and some kind of mechanical lever or crank or ratchet that we can use to ratchet up the pressure. When do you use one? You're going to always use it. It's appropriate to use it on an arm or a leg wound with massive bleeding. Sometimes, like I said before, a really horrible injury like an amputation may not bleed at first. That's because sort of there's almost like a moment, I'll use the word shock, but it's not the same as shock that we'll talk about later, but there's almost a moment where the body is so shocked that something's happened to it, that the vessels actually retract when there's been an amputation. Eventually those vessels are going to relax though, and the bleeding will be so intense that you'll be much better off if you go ahead and apply that commercial tourniquet straight on before that bleeding starts. You can lose a lot of blood before you get a handle on the bleeding and get it controlled. So in the case of an amputation, as I said before, you really need to go ahead and use a tourniquet if at all possible. All right. So how do we use a tourniquet? Well, whatever tourniquet you use, you're always going to pull it as tight as you can and remove any slack before you use the ratcheting device to crank it down. This is super important because any kind of slack will actually, if you leave slack, it's going to defeat the effectiveness of the tourniquet. Once you have removed all slack, then you can start tightening it, and you're going to tighten it until the bleeding stops or until you cannot tighten it anymore. You're looking to see blood stop flowing. If bleeding doesn't completely stop and you have a second tourniquet, you can always apply a second tourniquet right next to the first one, because both tourniquets next to each other are actually affecting the same flesh. So it works as one big tourniquet. That works much better than two tourniquets that are separated from each other. Some folks are likely to need a double wide tourniquet like that anyway, just straight off the bat, especially folks who are larger or folks who are very muscular. And then finally, another key rule for using tourniquets, you have to recheck your tourniquet. A person can move and the way that the muscles compress can change and bleeding can renew, or a person can be moved. And in that movement, the tourniquet can get jostled. So super, super important. Always check back for bleeding and make adjustments as needed. Okay, so once you know how to use a tourniquet, tourniquets are really fast and easy to apply. In our CERT classes in Arlington, we start off, it takes us about 30 seconds or so, we're learning, but then we can often do it in less than half that. So a little practice really, you can get faster and faster. Keep in mind, if a tourniquet is needed, the sooner you apply it, the better your outcome is going to be, because blood is life. If you think you could use one or you should use one, just use one. It will hurt. If you are putting a tourniquet on a person, they may say, wow, that really hurts. And if you've taken a CERT class, you've probably put a tourniquet on yourself before or on someone else, and you probably already know that. If you're taking class with us, like our in-person class, it'll give you a chance to feel how tight that can get. But keep in mind, it might be uncomfortable, but you're saving a life and the alternative is dying. So you're going to have to do it. Couple things, remember, tourniquets have been proven, they can be on for much longer than 2 hours, certainly safe within 2 hours. And they can be used on children, but the commercial tourniquets are really not made for very small children. We'll talk as bleeding control goes on and talk about some other ways you can handle that. All right, so where do we apply tourniquets? 4 locations only. If you take a look at the slide, the locations are designated by those black boxes. They are high on the limbs. They are worked up as high on the limb as you can possibly go on each extremity. So some first aid classes will tell you to apply it right by the injury. Don't do this. If there's heavy bleeding, it's really hard to recheck for other injuries, and shutting it all down is really unlikely to cause additional problems, but missing another wound would cause problems. So you can see on the picture, if you place the tourniquet high on the arm, across the top of the bicep, you put it up as high as you can, bring it up as high as you can inside the armpit, as long as it can stay square to the arm, horizontal basically, instead of at an angle. You never put any kind of tourniquet over any joints. So it never goes up over the shoulder joint. It stays down low. On the leg, you work it up. You work it up as high as you can on the inside, and the strap can be slightly angled on the outside. You can see in the picture. It can really kind of bite down into the glute there, the hip. Check for things in pockets before you tighten down. If you tighten down on keys, you can actually cause another injury and cause great pain. And if you tighten on something like a cell phone, then the compression is going to be uneven and it won't work. And then don't forget, you can always use more than one if you need to. All right, so I have a SAM-XT tourniquet right here. So I thought I would show you guys. Mine is not orange and black, it is blue and black, same idea. This is a winner of a focus group that Dr. Reed-Smith did in Arlington with just regular citizens, the folks who are ideal for UHA, because people like the feedback of hearing the teeth click into place when the strap is pulled tight. So they know that it's actually, that the strap is set before you start tightening. Folks can learn it really fast, and with practice can get really fast at it. So SAM-XT has a buckle, has a strap, and it has a windlass, and it has a windlass catchment area and a strap to keep that windlass in place when you're done. A couple things about SAM-XT. Not only the SAM-XT, but really any tourniquet. So let me just back up a step. They always work best when they're applied on bare skin. So wherever possible, remove bulky clothing, sweatshirts, anything like that. You might be able to keep some thin material there, but wherever possible, remove clothing before you apply a tourniquet. All right, let me show you another tourniquet. Actually, I do not have a sample of the combat application tourniquet. I haven't met with me. But anyway, the reason why we share combat application tourniquet with everybody is it's really easy to apply. It has a Velcro strap, which helps people, especially learners, feel that it's very secured. So once you put it around the arm, you use the Velcro to tack it down, and you make sure that you can't fit 2 fingers underneath before you start turning the ratchet. and you know that you have it, you know that you've removed all the slack at the beginning. Really easy to use, so highly recommend it for folks who aren't really familiar with them, but need one that they can use right off the bat. It's just quick and easy. All right, let's take a minute, and if you guys don't mind, I'd like to show you how to put on a SAM XT. You guys probably have seen this before. I've done this before, but it doesn't hurt. All right, so you guys can see the buckle there. Now, when you put a strap through the buckle, it isn't like in the airport, or it isn't like in an airplane. It doesn't go like that. It actually goes through that hole there. So you feed the strap through the hole there, like that. And let me put this on my arm. And remember, guys, I want to work it up as high as I can on the inside of my arm while still keeping it horizontal, right, and square. Now, I always want to put the ratchet on the outside just because if I were moving around, I could easily jostle that a bit. So try to orient it toward the outside of the body. Now I'm going to pull it, and I want to see if you guys can hear it click. A little bit there. Did you guys hear it? If you heard that click,
Catherine,
post in the
is
chat.
it possible for you to people double click on Catherine's screen and you'll be able to see her more clearly?
You guys can see me? Okay, so hopefully you heard the click. Now, when I've got that click, I can't fit my fingers underneath the strap anymore. So it is set. And at this point, I can start turning my windlass. Now, I've taught you all that you turn it until bleeding stops or until you can't turn it anymore. For the purposes of keeping this tourniquet in good shape, I'm not going to do that, but let's assume that I did. And when I can't turn it anymore, I'm going to put this into the catchment device right here. I'll put the strap over, which keeps this in place. And I can even put the time that I applied the tourniquet right here. For tourniquets that don't have a little time strap there, you can always just write it on the arm of the person, on the forward, on the shirt. You can put a piece of tape and put the time on there. And then you always want to tie down the strap because you don't want any loose ends to get pulled on anything, and you don't want the tourniquet to get loosened. So guys, you're never going to loosen a tourniquet under any conditions yourself. That's something for a doctor to do or medical personnel in the hospital. So once it's on there, it stays on there. If you have to, you can apply another one, but you don't take off the one that you put on. Okay, so moving on, I'll show you a few other tourniquets. If you take a look, the one there on your left is a soft T tactical tourniquet. It has all the same elements. Instead of a buckle, it actually, you can see at the top of that tourniquet, there's like a little gripper clip. That's where you would remove the slack and set it. And then you can see it has a ratchet, and then it has triangular catchment devices. In the middle, that's a military emergency tourniquet, or a MET. And in this case, you pull the strap really tight through the ratchet and then start turning the ratchet. And on the far right, that's a ratcheting tourniquet. This doesn't have a windlass at all. The way that you tighten it is you pull the buckle that's at the top of that tourniquet, and it's like a ski boot. So it'll ratchet tighter and tighter and tighter and tighter. Now that I haven't really practiced with that one, but to my understanding, if a person has hand strength issues, that is an ideal tourniquet because it's really easy to adjust with that ratchet. And there is a pediatric version of that one available as well. So all of these work to control bleeding. All the tourniquets you've seen work to control bleeding. The best tourniquet for you is simply the one that you can practice with. All right. We review improvised tourniquets in our hands-on class, and it really takes the time. We like to devote the time to do it because it's really important to understand how tourniquets work and how to understand how to make one if you need to. To make one, you're going to need those same components that we've been talking about. So you're going to need something you can use as a strap. something you can use as a windlass, and something that you can fasten it all down with. What those things are, though, it does matter. So if you're folding something to be your strap, you need to fold it flat to be about 2 inches wide. Remember, we don't want it to get ropey because we don't want to cause nerve or flesh damage. So don't roll it up, fold it. That rolled up cloth is just too narrow. Don't use a rope, don't use a shoelace or anything skinny like that because it'll cut through flesh. On TV, people use belts all the time. But now that you know how tourniquets work, you can see the problem. A belt, you can't tie a knot in it. You can't twist it tighter and tighter. So it's a bad thing to use for a tourniquet. It's not ideal. They're not flexible enough. So you also want to avoid stretchy fabrics because obviously you're trying to tighten something. So if you're tightening it and it's stretching, it defeats the purpose. So use something that's kind of tougher, like cotton or denim. You can rip up some blue jeans, rip up a cotton shirt. Use something solid for your windlass because you're going to exert a lot of pressure on it. Use something that's not going to break. So one pencil or one pen might not work, but if you put a bunch together, it might work. You can use a stapler. You can use scissors. You can use a utensil, a metal utensil. Get creative, a steel ruler, stick, chopsticks, anything you can find. And then finally, you'll need something to tie the windlass down when you're finished tightening it. So this is where that shoelace might come in. And you need to use as many ties as you need to make sure that that windlass doesn't loosen. And this is especially important for improvised tourniquets. So you want to make sure that when you tie your windlass down, you secure it very closely to the limb, but you don't let it unwind as you do so. So improvised tourniquets are not as good as commercial tourniquets. You may need more than one, but it's a really important skill to have. The next video we're going to watch is a medic showing you how to put one together. But before I launch that video, I want to make you guys aware. Afterward, I'm going to ask you what the medic did differently than what we've taught you tonight. There are a couple things that happen in the video that actually are not ideal. So pay close attention and we'll talk about it after the video.
On this channel in the past, we've talked about a couple pieces of medical equipment a lot, and those are tourniquets, chest seals, packing gauze, and splints. And today on the channel, I want to show you guys how to improvise this. If you don't have a commercial device out there, these are some techniques you can use to accomplish the same objective. I would like to point out that this should never be your plan A. Anybody that carries a strip of cloth in their first aid kit and a little stick saying, well, I'm just going to do a makeshift tourniquet, I would not recommend that at all. In the Boston bombing, there were a lot of makeshift tourniquets applied, and what they found is that a vast majority of them were ineffective. Now, you might be thinking, well, what's the problem with a tourniquet that's not 100% effective? And I'll tell you. So if you have a tourniquet that is not completely tight, it's not occluding blood flow 100%, all you're actually doing is occluding the vascular return in the leg, not the arterial discharge. So you will still have bleeding from the artery, but now you've stopped any vascular return into the body, so they're not getting any of that blood back. And you can actually speed up blood loss. So it's really important that if you use this technique, you do it right. You know, the same thing goes for chest seals. Chest seals are actually pretty easy to make, but they take a lot of time. So all of these things I'm showing you, you should practice. You should make sure you're proficient in them if you foresee a situation where you might have to do it. You know, having this knowledge is something that's good, but you have to understand that there are limitations to it, and plan A should always be a commercial device because, quite frankly, they're more effective and they're quicker to apply. So let's start with tourniquets. So to make a makeshift tourniquet, you just need 3 things. And right here, I have a cravat, which is a triangular bandage. It doesn't have to be this. It can be any kind of fabric, and you're going to need 2 strips. So this is just a cut up t-shirt that I'm going to be using. And then you need something to act as a windlass. So I'm going to be using my X shears for this. However, this can be anything. This can be a stick. It can be a piece of silverware, what have you. It just needs to be something that can have a lot of force exerted on it and not break. So to make a makeshift tourniquet, the first thing you're going to do is you're going to take your main, most sturdy piece of cloth, and you're going to make sure it's pretty wide. You want this cloth kind of as wide as you can get it and put it over the arm or the leg that's bleeding. So you want it above the injury. So they're saying 2 to 3 inches above the injury site, just not over a joint. You're going to wrap it around the leg and you're going to tie just an over-under knot right across the leg. We're going to do it on the leg for this scenario. Then you're going to put your makeshift windlass inside that. You're going to tie another knot on top of that and potentially a second one depending on how well that fabric's holding. Then you're going to take your makeshift windlass and you're just going to start turning it. It's the same concept as a softy wide or another windlass tourniquet that you can buy commercially. You're going to turn that until blood flow stops. At that point, you need to hold that windlass right there. You're going to take the second piece of cloth and put it across and feed it through that windlass. And what that's doing is that's keeping it from turning back and loosening all the way. Once you have that secure, make sure that all the blood flow is stopped. If it hasn't stopped completely, try tightening the windlass 1 or 2 more turns. If that's not working, prepare to put a second tourniquet on there.
Okay, how'd we do? Before we move on, let's see if you guys caught what I was asking you about. There are a couple things that happened that were a little different than what we're teaching you tonight. Did anybody catch them? Let's see if you guys can post your answer in chat.
Nothing's coming up yet, Catherine.
Okay. Anybody notice anything? Yeah, there you go. That's a good one. He did not go high and tight. Absolutely correct. Absolutely correct. Thank you guys. Really good call. Really good call. All right. And then the other thing, it might have been hard to catch, but he was using his trauma shears as his windlass. And he was tying it down. And then as he went to make an adjustment, it actually unwound about a quarter turn. Did anybody see that? Yeah, if you saw that, you're absolutely right. Just that little bit of loosening could have allowed blood to escape the tourniquet to get past the pressure. So really, really important. You never want to loosen it. And you can avoid making mistakes with tourniquets by practicing. And that's the benefit of doing hands-on practices as well. You know, we teach online, we want you to get these concepts down, but really going through it with your hands makes a big difference. So we taught you the basics about the tourniquets. I want to review some of the common mistakes. So let's go through them really fast. If you think you need one, use one. Always tighten it as much as you can possibly tighten until bleeding stops. And if you can't tighten it anymore, consider using a second one. Another mistake, putting it too low in the limb. We just saw it. Always high and tight. Never loosen the tourniquet after you've applied it. Never forget to reassess. We talked about how it can get jostled or knocked. Super important that you keep an eye on it because bleeding control is only controlled if it stays controlled. So you got to keep an eye out for it. Now, if you guys are going to, most if not all of you are CERT. So you've probably already thought about whether or not you're going to put a tourniquet in your emergency kit. So remember, this is going out to the general public, but we do take a moment to make sure that people are buying their tourniquets from reputable suppliers. So that's going to be a medical or tactical supply source. Getting it from the manufacturer of the tourniquet itself is a great call. When you go through a third-party vendor or fulfillment situation, you're never exactly sure where you're getting it from. And there are a lot of knockoffs out there that may not work as well once you need to use it. So always use a reliable supplier. You're going to plan to pay somewhere in the neighborhood of $35 for a good tourniquet, and it's worth the money. Get one to practice on, like we just did, and then one for emergency situations, and practice, practice, practice. All right. So I'd like to hand over the mic to Sue now. We've talked about tourniquets, and she's going to follow me by talking about wound packing, and then later even pressure bandages. So without further ado, Sue.
Great. Hi there. To recap, the big picture is when we're faced with threatening bleeding, the first thing we're going to do, and hopefully you all know this by now, is always do direct pressure, okay? You can use your hands, your knees, as much of your body weight to apply as much pressure as possible. As Dr. Smith mentioned, that's really important. So for heavy bleeding in the extremities, as Catherine mentioned, that's arms or legs, you're going to use a tourniquet. First, if you have one, and if not, you can make one. It's a great option, but once again, high and tight. But if get some practice, you can do it in less than 30 seconds, okay? But if that's not possible, then we talk about wound packing. And that's another option for controlling bleeding from a deep wound, especially a gash or where there's a big flesh missing. It's ideal for wound packing. We fill up with the gauze to replace the missing flesh and apply direct pressure. It's effective, but remember, it takes longer. That's why we prefer the tourniquet if we can use that first on the limbs. But let's quickly, let's look at the anatomical places where you can wound pack. The highlighted areas on the slide right now are places good for wound packing, both the arms and the legs, the front and the back. So if you don't have a tourniquet and you need to, this is another option for that. But our next option is we talk about the junctional areas. That's kind of where the limbs attach to the body, and it's where you can't use a tourniquet, such as the groin, where the femoral artery runs close to the surface, or the buttocks, or the shoulder, or the armpit, and the very base of the neck. And these are areas you can't really affect or wrap a pressure dressing because you're going to affect somebody's breathing. So, and so you use wound packing and direct pressure. And certainly if you have hemostatic gauze, you want to use that too, okay? On the next slide, we're going to talk about wound packing where it's not effective. It doesn't work if there's a hole in the chest. There you got a breathing problem. If it doesn't work in the abdomen, the back. Basically, the cavities are too large and the blood pressures are too deeply buried to apply direct pressure for them in the packing. Although it's not highlighted here, the head and the front of the neck also are not areas recommending for wound packing. Direct pressure is probably the best because remember, once again, if we're the head and the neck, you need to worry about somebody's breathing, okay? Now let's look at the bottom picture here, the one with the X. It shows that with a deep gaping wound, direct pressure on the surface probably is not going to do any good. It's not going to stop the bleeding, okay? Because the missing flesh or space, the bleeding just continues to fill up the space. And putting on pressure on top of it just doesn't work. But if you look at the top picture, it shows that you completely fill the void with a tightly packed gauze and then apply direct pressure. The direct pressure from the top packs down and blocks the blood from bleeding. It's vessel. It holds on to the deep vessel. So the cotton plug that's actually applying direct pressure to the vessel, okay? Now, gauze works great when we promote clotting. And let me hold this up so you can see it. This is, you see the gauze, it's got big holes in it and stuff like that. And because of the open weave, the platelets cling well to it. And it's even better if you have the hemostatic gauze because that's coated with the chemicals that promote the coagulation and clotting. Gauze is particularly helpful in the junctional areas where you can effectively wrap a pressure dressing, okay? What we're doing here is we're teaching you not only uses, but the thought process. So in an emergency, what are you going to use? If you have gauze available to you and the wound's in an area that you can do wound packing in, use it. If you have the hemostatic agents, you can see pictures on the slide of those different brands, use that. But remember, if you're in a mass casualty event, you may not have a lot of that. So you may want to save those to treat the junctional areas because most of us are not going to carry huge amounts of the hemostatic agent. It's relatively expensive. Okay. So warning, we're going to show you some bloody pictures of a large wound in the next few sites. Slide, excuse me. Okay. The first thing you do, this is a deep bleeding wound, a gash. It's a good candidate for packing. Looks like it's an underside of the bicep, but it's cut by a knife. The idea is to fill up the void with tightly packed gauze and then apply sustained pressure from the top. Okay, and we're going to go through this step by step, and then I'm going to do a demo on how to do it. First, you have to see the wound first, so expose it. Okay, so obviously, the wound packing is most effective if you scoop out the congealed blood before packing. Basically, blood congeals, turns into a jelly-like substance when it's exposed to air, and that can cushion the packing and pressure and defeat your efforts. So what we're going to ask you to do is probably the grossest thing, but what we're going to do is we're going to ask you to remove that. And so you stick your finger in and move that coagulated blood, okay? When you do that, you want to be real careful because we don't know, in an injury like that, there may be broken bone, or maybe it was injured, there's some other kind of fragments of metal or glass or something like that in there. So you're going to want to wrap your finger in some gauze before you stick it in, okay? You guys see that? Okay. If you have gloves, use them. If not, you're going to have to make a decision on how you're going to handle it. When you reach into the wound, you may be able to see or even feel where bleeding is. If you put your finger in, you may feel a little wiggle or a pulse or something like that. And basically, you want to pack towards that. You're going to be pushing your packing towards that area, okay? Next, we're going to start packing the gauze. You're going to push it in firmly, try to fill every square millimeter, and I'm going to demo that in a minute. The main thing to remember is don't be timid or shy, be bold, and do not stop short of packing as much as you can into every place. An empty space is going to defeat your goal. Don't worry about not being sterile. Gauze is best, but if you don't have it, you can use anything cotton. It's much better than synthetics. And don't worry about the sterilization or whatever. You have to use a sock or something like that. We're keeping the person alive. We can deal with them in the hospital with antibiotics if they have a problem after that. Okay? The next thing you want to do is when you can't cram any more gauze in, what you want to do is pile it up on top and push down hard and use your body weight. Because remember, we're going to ask you to do that to hold the pressure for 5 to 10 minutes. That's a long amount of time, and we want a whole lot of pressure. So if you can use your thigh or your body weight or something else like that to hold that, that's really helpful. If you're using the hemostatic agent, it probably will get done in about 3 to 5 minutes. It'll be a little faster, so that helps if you have that available. Okay. After the proper amount of time, you release the pressure slowly, but don't remove the gauze. We're not pulling anything out. We're not removing anything. Let's see if it's still bleeding. If it's still bleeding, reapplies it for a couple of 2 to 3 more minutes, okay? And then what we're going to do is we're going to try and apply a pressure dressing once the bleeding has stopped. And we're going to show you how to do that in a minute. But first, I'm going to demo the packing on the fake injured limb. You can see me?
Yes.
I'm very flexible, okay? So if you believe that, then we know, okay. If it's not bleeding a lot, I'm not going to do a whole lot. I don't have to really worry about it. But the first step is direct pressure. Can anybody tell me how I should do that? Okay. First, I have to expose the wound, so I'm going to rip whatever clothes or cut whatever clothing away. Then I'm going to get the gauze ready. And one neat trick with this is what you do is I'm going to throw it over my shoulder so that I have it, I can feed it really easily, okay? Now I'm going to carefully insert my finger. I'm going to wrap it in. I'm going to insert my finger into that and feel for the location of the bleed. Can I feel it? Can I feel where the pulse is or anything? I'm going to also scoop out anything I can. That's the gross part, remember, but we're going to get that out. Now I'm going to start feeding the gauze into that place that I saw where it was bleeding from. That's where the vessel is, the blood vessel. I'm just going to keep feeding and feeding and feeding. Really pressing hard in that, not leaving anything there. When it's totally full, then what I'm going to do is going to take the rest of the gauze and just pile it on top, okay? And I'm going to push down hard with my body weight, okay? And that's why when a knee or something else comes in, can come in real heavily. And I'm going to hold for 5 to 10 minutes, 3 to 5 minutes if I have the hemostatic agent. And then I'm going to gradually let up a little bit and see. I'm not taking anything off. I'm just looking to see if it's going to still bleeding. If it is, I'm going to put it right back on for a couple minutes. Okay. Before we move on to the pressure dressing, can anybody remember how long we should hold direct pressure after packing the wound? Anybody? Get any answers, Janine? Okay. Well, we've been talking about pressure dressings.
You did have a correct
Okay.
answer.
Saying
Well
five-
done, you
5
guys.
minutes, 10 minutes.
5 to 10 minutes. Good job.
Excellent. And I got to tell you, if you never, that is a really long 5 to 10 minutes, especially if you're in a stressful situation. Okay. So you're going to think it's forever. Okay. Now, remember, we've talked about tourniquets, we've talked about wound packing, but we're going to use pressure dressing if we can with wound packing, okay? And basically, it's an ACE bandage. It's one of those things I'm sure you've seen that we used to use a whole lot with sports. And it's good because it stretches. And as you put it on, you pull it as you go, and it makes things much tighter, okay? It holds the pressure on the wound, which is exactly what we're trying to do, okay? You want to use it to provide constant direct pressure to the wound. So it's going to hold it for you. So you, especially if you're in a big situation, you can get somebody, you can keep the pressure on the wound and you can go and help someone else. They're very effective, especially on arms and legs, although I would use a tourniquet first if there's heavy bleeding. But they're less effective if the wound is not completely packed. That's why we're talking about really pack everything, okay? It's good as an alternative to tourniquets for smaller limbs. Remember, if you have a kid or something like that, a tourniquet is probably not going to fit. So any child, let's say up to grade 3 or so, this can be more effective than a tourniquet because the arm is just too small. But keep in mind, it takes longer. It may take 2 to 3 minutes, but you don't want to rush it because one of the things about it is you need to hold it tight. And if you are fast, you're going to drop it. We all did that when we were learning how to use it. And then you have to re-roll it and start again because you really need that pressure. It's not going to be useful unless you're holding it tight. We're going to show you a video on how that works. And as a reminder, if your video freezes, log off and log back into the session, okay?
My name is Randy White, and I'll be demonstrating the pressure dressing. Okay, the first thing is, of course, is BSI, to make sure that you have your gloves on. The next thing is you'll need some 4x4s, and as soon as you get there, you want to make sure that you cover that and put direct pressure, pinpoint pressure over that bleeding. Okay, once you've done that, you may need to move on to a different skill, like for instance, airway or treating for shock or something like that. So I'm going to put a pressure dressing on it, okay? Now remember, once you put this on here, you shouldn't be looking at it anymore. I'm going to put an anchor wrap on, and an anchor wrap really is just to keep my bandage from slipping all over the place. And now I'm going to, again, keeping direct pressure over the top, I'm going to be moving the wrap distal to proximal, proximal to distal, okay? And as I'm going to make this look a little pretty, okay? Now, when I want to do direct pressure over the site, okay? I'm going to bring the bandage around, and now I'm going to move the bandage over and put direct pressure over the site with that. I'm going to come around, being careful now not to drop my roller gauze, because if I do, then I've lost the ball game. And it's a lot easier to drop when you're rolling backwards. Now I'm rolling forwards again. I'm going to do this one more time. Here, and one more time here. Okay. Now I'm just going to finish it up. Making sure that I put plenty of my roller gauze over the top. Again, tightening up as I go, making sure that the bottom side is loose so that I get good pulses. Now I'll tape and tie and tuck.
Okay, some tips on this. Unlike the packing gauze, which I said to toss over your shoulder, this time we want to keep it rolled up. And it's really important that we don't drop it because we're going to lose the pressure. So you can pull on the roll each time you roll around. I don't know if you can see that or not. Just so you can pull on it. If you do drop it, take the time to pick it up, roll it back, and start again, okay? Otherwise, it's hard to really get a good wrap, and we really want a good wrap. You also want to keep the full width of the bandage in each wrap. You don't want it to rope, okay, into a strand. You don't want it really thin. The one exception is when you twist right over the injury, that's when you do it to add additional pressure, okay, when we twist. But normally we want it really straight, okay? And to finish, what we do is we put the finger under the last wrap and tuck it through, okay? We don't use the clips, and it definitely is a little slower than the other stuff, but you need to do it. If you rush too much, you're gonna drop it and you're gonna lose your whole pressure and you're gonna have to start again. But once again, you're gonna then check for bleeding, bleeding, okay? You can't really use it on junctional areas, okay? It just doesn't work. But this is kind of this picture shows a clever way to keep a pressure dressing on a junctional area, such as the armpit or the base of the neck. And actually, if the guy puts his arm down, it's gonna hold the pressure dressing a little better. Note, this isn't a tight pressure wrap. It's just holding the wound pack in place, okay? And you can use it also on the groin or the buttocks. You can swaddle it around the hip or the opposite leg. So this is kind of a way of keeping some of the dressing on, okay? Now that we've covered several techniques to manage bleeding, what technique would be best to manage very heavy bleeding in an extremity? Can you post your answer in chat?
Someone saying tourniquet.
Good, yes, that's right. That's right. The first thing we can use for an extremity is heavy bleeding is a tourniquet. Excellent. What techniques would you use to stop bleeding for a deep wound or a big gash?
Or a wound in the junctional area.
Yeah, or a wound in, yep. Yes. Yes, very good. Everybody got the packing and as I say, if you can use the pressure dressing, that's great. If you can't, but as you see, okay. So that's it for circulation. Severe bleeding is not the only preventable death. The next fastest preventable death is from a blocked airway. So let's look at that.
I did see an interesting question in chat or comment rather, and that was that after you've applied a pressure bandage, one of our participants said you should always check for capillary refill. And I thought that was such a great comment. And coming from CERTs, I think it's kind of safe to say, you know, we talked about pressure dressings. You can use it to hold pressure on a wound once bleeding is controlled, but you can also use a pressure dressing almost like a tourniquet. And in some respects, you might even use it as a tourniquet on a smaller limbed person or on a child. In that case, you would not be looking for capillary refill. You'd be looking to completely, if you're trying to use it as a tourniquet, it would need to be tight enough to stop capillary refill. So you guys as CERTs understand the distinction I'm making. We usually don't get into this so much with the general public because we don't want to confuse anybody. But remember, it is a tool and you have to decide how you're going to use it. You can use a pressure dressing without using it with wound packing. You can use a pressure dressing on a small limb, almost like a tourniquet. It just depends on your application and your situation. So I hope everybody understands what I'm saying there. And Char, I hope that helped elaborate on your comment, which I thought was a very good one. Okay, Chasta, looks like we're about ready to roll. Are you ready?
Yes, ma'am. Just tell me when to start.
Okay, take it away.
All right. Welcome back, everyone. The airway is the tube that carries air from your nose and mouth to your lungs. An injured person who is unconscious could die unnecessarily from a blocked airway that could be pretty easy to open. One way this could happen is if someone is unconscious and laying on their back, the tongue can slide back far enough to block the airway. If someone is unconscious, not breathing, and on their back, you can try a basic first aid maneuver called the head tilt chin lift. If you've taken CPR, which I recommend you do, you may have seen this there. You put your hand on their forehead and with your other hand, 2 fingers under their chin and gently tilt the head back while lifting their chin up. This lifts the tongue up off the airway enough for air to pass through. Check for breathing and try a second time if needed. Next slide. The second thing to do is to put them in the recovery position. Basically, this just means roll them on their side to keep their tongue off their airway. It also allows any fluids to drain out rather than collect in the airway. We have a video to show you how to put someone in the recovery position. As a reminder, if your video freezes, log off and log back into the session.
How to put someone in the recovery position. If a person is unconscious but is breathing and has no other life-threatening conditions, they should be placed in the recovery position. With the person lying on their back, kneel on the floor at their side. Place the arm nearest you at a right angle to their body with their hand upwards towards their head. Tuck the other hand under the side of their head so that the back of their hand is touching their cheek. Bend the knee farthest from you to a right angle. Now, carefully roll the person onto their side by pulling on the bent knee. The top arm should be supporting the head, and the bottom arm will stop you rolling them too far. Open their airway by gently tilting their head back and lifting their chin, and check that nothing is blocking their airway. Finally, stay with the person and monitor their condition until help arrives.
So to recap, anyone unconscious goes into the recovery position to keep their tongue off their airway and to allow fluids to drain out. This is especially true if you're not working on them. Easier to work on them on their back, but then put them in the recovery position. This is also important for someone passed out, drunk, or overdosed. Don't leave them on their back. But remember, this is only for unconscious people. If they are conscious, always allow them to choose a position of comfort. That's it for airway, much quicker than the circulation section. Remember, airway was second because it's the second fastest way to die unnecessarily after bleeding out. The third fastest way is by injuries that obstruct the mechanics of breathing, meaning lung function. Before we dive into that, let's just take a quick moment to review how breathing normally works. When you take a breath, what's happening is the muscles in your chest wall and diaphragm contract, expanding the size of the lungs. That lowers the pressure in the lungs, which draws air in through the nose and mouth. Breathing out, it's the opposite. If you put a hole in the chest wall big enough to let air through, the system gets short-circuited. Sorry, Catherine, I have that we are doing the chest slide next. So did I get backwards?
It's okay. This is.
Oh, my apologies, everyone.
It's okay.
Forgive me. No, forgive me. So allow me. I'm sorry, everyone. So on this slide, we're dealing with the penetrating chest wounds. These injuries are very common in shootings. Before reading the words, look at the picture on the right. There's a hole in the chest wall letting into the air into the chest cavity, which prevents the lungs from expanding normally. Called pneumothorax, air in the chest, or the sucking chest wound. So if someone's injured and not breathing well, look for holes anywhere from the belly button to the shoulder, front to back. There may not be bleeding much, but they are still maybe deadly. So check for the exit wounds as well. So how to treat this? You cover the hole, ideally with a vented chest seal. We have a video to show how the chest seal works. So as a reminder, if the video freezes, log off and back into the session.
Penetrating chest trauma can be immediately life-threatening and needs urgent medical intervention. This is particularly the case where the wound communicates with the chest cavity, causing an open pneumothorax, potentially collapsing the affected lung. The lungs are normally soft and compliant and fill the pleural cavity. On inhalation, the intercostal muscles lift the rib cage, expanding it and creating a negative pressure. With an open airway, the lung expands to fill the space. This is assisted by the muscular sheet known as the diaphragm, contracting and flattening, also enlarging the chest cavity and expanding the lungs. In open pneumothorax, a wound creates an open passage between the external environment and the pleural cavity. Air can potentially pass in and out of the chest cavity through the hole in the chest. With the loss of negative pressure in the pleural space, which would normally hold the lung in an expanded state, the lung on the affected side will now collapse. With inspiration, the rib cage will expand and the diaphragm flattens, but the negative pressure may now pull air into the chest cavity through the hole in the chest wall. Depending on the size of the wound, the affected lung may partially expand or may remain completely collapsed. The effect of air being drawn in through the hole in the chest has led to the term sucking chest wound, though this movement of air may not always be obvious. Treatment of open pneumothorax involves applying a seal to the chest, which, by means of a valve, will allow blood and air to be expelled during exhalation, allowing a negative pressure to be created and the lung to re-inflate.
So to summarize, here are the steps for applying a chest seal. First, we clean the area around the wound so the seal can stick. Stick on the seal with the vent directly over the wound. Can you improvise a chest seal? Yes. To improvise one, you need something to block the airway. For example, plastic trash bag, candy wrapper, anything you can find. You tape 3½ sides over the hole. The half side is left untaped is meant to allow the air out of the hole while the plastic is drawn in and blocks air coming in during inhalation. So you monitor the person with these injuries very closely. This is super important. Even after covering the hole, you need to constantly monitor and reassess. This is a temporary fix at best. This person needs medical attention ASAP. One reason is even if the hole in the exterior chest wall is covered, air can still build up in the chest cavity. For example, air can also escape into the cavity from a hole in the lung, and that can eventually collapse the lung. This is called tension pneumothorax, and it can kill pretty quickly by interfering with respiration and circulation. So you need to monitor for these symptoms. Can anyone tell me what increased respiratory rate is? Is anything in chat? So we have the 32 can do. It's the panting, breathing like you're sprinting, 1 or 2 words speaking in between breaths. So people with this can go downhill very quickly. The best you can do with this is to burp the wound to let some of the air out and get them help ASAP. These pictures show you how to burp a wound. First, you peel back the seal. You massage around the wound to open it up and let air out, but don't stick anything in there. Then you cover it back up. You'll need to do this repeatedly as air continues to build up. The last part of SCABI is everything else, and for that, I'll hand the mic back to Catherine.
Okay, thanks, Chasta. So we've gotten to the E in SCABI, and that stands for everything else, like Chasta just said. In the next few slides, we're going to talk about the importance of monitoring mental status, treating for hypothermia and shock, and providing psychological support to the wounded. All right, mental status. We monitor a person's mental status or level of consciousness simply because it tells us, is their brain getting enough oxygen? We can tell if a person's alert and oriented by asking them 4 basic questions. And those basic questions are related to person, place, time, and situation. And it sounds like, hello, can you tell me your name? Can you tell me where you are? Can you tell me what day it is? Can you tell me what happened to you? If they can answer all those questions, they're alert and oriented, and this is good. If the person isn't alert, can you get any response to a verbal cue like, sir, can you squeeze my hand? If you don't get any response to a verbal cue, see if you can get a response to a painful stimuli. So it can be things like pressing a nail bed to a nail bed, squeezing the trapezius, like the classic, I'm going to give you a back rub muscle between the neck and the shoulder. Some folks have learned to take the knuckles and to rub it up and down on the sternum, which is temporarily very uncomfortable. May not always be appropriate depending on the wounds. Like if a person has a chest wound, that may not be a good option. That's why I gave you other options. All you're really trying to do is see if they react. If a person's unconscious and they're not reactive to any of those stimuli, then we would say that that person's unresponsive. It's really critical that you guys understand what these words are because you're going to be communicating with the first responders. And you're monitoring for changes in mental status, particularly declining mental status. If you're noticing that somebody was alert and now they're only becoming verbally responsive, you're going to do a couple of things. You're going to look to see, again, assess, was there a wound that's affecting breathing? Did you do another inspection? Did you miss a wound? Check the bleeding control. Did a wound that you previously had addressed start bleeding again? These are things you need to do to help monitor a person's mental status. This is really critical. All right, another thing we're going to do is we're going to treat hypothermia. A quick hypothermia question, guys, and I want you to answer this in chat. It's summertime. It's 90 degrees outside. Can a person with a traumatic injury experience hypothermia in 90-degree weather in the summer? Type yes or no in chat. Let me see what you guys are saying as an answer. I got a yes. I got a yes. I got a yes. You guys rock. Unbelievable. Well done, you guys. Well done. Yes, of course. So people with a traumatic wound are going to lose body heat. They lose it because as we treat them, we tend to remove clothes, but also the body's response to shock and traumatic injury is to we lose body heat because we're shunting to major organs. So an important part of everything else is preventing hypothermia. What can you do? All right, well, you've got to keep the injured person warm. As you know, and we've talked about it already, decreases in body temperature interfere with blood clotting, and that is deadly. So get ahead of it. Treat for hypothermia immediately. It's much easier to prevent hypothermia than to treat it once it's set in. If you're dealing with trauma and traumatic events, assume you're treating hypothermia. All right, here's another way to think about it. You just have to think of every way that you can help the injured person stay warm. So how do we do that? All right, you're going to bring them out of wind, bring them out of water, keep them dry. You're going to use layers to bundle them up with as many layers as possible. You want to insulate them from the earth if they're lying on it or a floor. Those things are cold and they can pull heat away from a person. So you want to put a jacket or a blanket or even a cardboard box underneath, anything you can find. You want to retain their body heat with those blanket coverings and layers. And just as an aside, you always want to use Mylar as your outside layer, never directly against the skin. You want it to reflect things back in toward the body. These are all things that work. Monitoring for shock. Also with traumatic injuries, you must be prepared to treat for shock. It is something you're going to do. You're not even going to ask about it. It's something that you're going to do. We've used the example of blood loss frequently in our training tonight, but you should know that shock can be caused by many other injuries and conditions, not all of which you can see, that affect fluid balance. So other examples could be fluid loss caused by severe nausea or a blockage due to a blood clot, so your body's not getting fluid. Injuries to the heart, lungs, or head can cause these problems, even an overwhelming infection. So just remember, you might not always see the injury. It might be internal in a traumatic event. You don't really need to. The earlier you start treating for shock, the better outcomes are going to be. Don't wait to see the worst symptoms before you act. What does shock look like, guys? Well, early symptoms of shock, the body is compensating. So it's speeding everything up to try to make sure that you're still getting oxygen and nutrients. So the person's going to be experiencing anxiety and restlessness, some confusion, some lightheadedness. Skin might look pale or ashen. Definitely lighter or lightened or bluish lips and fingernails. You might see cool or clammy skin. Sometimes people are profusely sweating in the early stages. You should expect a fast pulse rate and fast breathing. But as shock progresses, it starts to look very different. Things start to slow down. Blood pressure falls, breathing rate falls. The person becomes confused. You start seeing mental status begin to decline. So we don't want a person to progress. And you might come upon a wounded person in any stage of shock. So just remember, if it's been a traumatic event and traumatic injuries have occurred, you're going to be treating for shock. All right. So how do we do it? Bottom line, it's much like hypothermia. You want to keep the person warm. You're going to keep their airway open and positioned for drainage. If they're conscious, you're going to let them choose the position of choice. We're going to say that again and again and again. But you want to be aware people who are in shock may lose consciousness. So a special note about fluids. Thirst is a sign of shock, but vomiting is also a sign of shock. So if a person is very thirsty because they have lost fluid volume, you can help them, but encourage them to take very small sips of water, very small. There's no guzzling, because the last thing you want to happen is for the person to lose consciousness and then vomit and aspirate. That's deadly. So small sips are okay. And then remember, if you've got a person who's in shock, be very, very careful with them, because they could lose consciousness. You want to make sure you're ready to put them in the recovery position if so. Again, if a person's conscious, in the position of choice. People have a way of naturally assuming the position that their body feels most comfortable in and that minimizes discomfort and pain. You could expect to see a person with an abdominal trauma to be on their back or their side with their knees up or bent. You could expect a conscious person having breathing difficulty to be sitting up at 45 degrees or even tripoding, which is when you lean forward with your hands on your knees and you sort of, you're kind of creating a tripod to try to stretch out your back, which is you've got a lot more lung in your back. And so that's very effective. If a person's unconscious, though, you want to put them in recovery position. There are a couple special notes we want to highlight for you. If you have a known head wound, you may consider elevating the head a little bit, just 15 to 30 degrees. And if you have a known chest trauma, you may want to consider putting them in the recovery position with the injured side down. That would protect the good lung function. Because you're not having body weight, you're not pushing the body weight against the good lung that's left. You're helping it perform. All right, so warning, guys, we have a graphic and intense picture coming up next. This is a picture that was taken at the Boston Marathon. This is a bystander who is comforting a wounded person. And we just need to take a moment and really take the slide in. It's emotionally intense, but it's also really important what's happening here. There are times when you don't have anything. But even if you can do nothing else, you can provide psychological support to help comfort the wounded and help them fight to live. Paul said it before, this can make the difference. Stay with them, talk to them, let them talk to you about who they love and care about. You be their connection to the living people that they love. Psychological first aid can make all the difference. Emotional support, hope, and connection can pull us through, even through really bad situations. And we can't know the outcome when a person have a grievous wound. There's no way we can see the future. But if you're able to stay with the person and support them so they don't have to go through this alone, then no matter what happens, you've done a good thing. All right, so we've reviewed all the aspects of rescue. You can see the elements that we've covered in the slide here. Are there any questions on any parts of this before we move to our last section, which is report? Any questions? Okay, so I'm going to give the mic back to Douglas, who's going to wrap things up for us with 911 reporting. Douglas?
Great. Thank you. Finally, the last R. Why are we only talking now about calling 911? Your first aid courses taught you after you did scene safety to do that first. A high-end emergency, like an active shooter, a mass casualty bombing, is a different kind of event. You are one of very few people in the crowd likely who can render this level of TECC care and support. So for high threat situations where we're talking about ongoing danger with more casualties than resources, reporting is the last thing you personally do. There were, for most of the traumatic scenes that we've looked at tonight from those events, there were hundreds of calls to 911. Don't worry, 911 likely knows if it's that big. Your job is to start saving lives. You can make a critical difference with these core skills. So after we've handled the first 3 R's, so it is finally time to report. Remember, please, 911 professionals operate from proven templates to gather their data. They will do this really efficiently if we let them do their job. We are being debriefed here. I know that's challenging for emergency bunnies like ourselves, but we are being debriefed. So let them follow their script and do it right. Reporting, they'll ask, where is your emergency? 911 does not track your cell phone. There are simply too many of them. 32,000 people roughly in Arlington between Roslyn and Ballston in each half mile of a major artery. So it's too many. And what they can track is the nearest cell tower. That's great for police forensics later for some crime, but it doesn't do any good here. You need to describe the specifics of particularly for a street address for a building, be sure to give the floor and the room number, the interior directions. And like you would in reporting a regular emergency, get someone to the door. If no one in the room really has where the meeting is taking place, you were all led there or something, if you can do no better, use your own GPS on your own phones, or worst case, I'm not being sarcastic, look out the window. Tell the operator what's going on. They are trained to work, for example, with children calling in an emergency about their parents. They can debrief people on location and help you figure it out. And it can be done. They'll ask, what is your emergency? Be concise and calm about what happened. This requires a detachment you do not feel. Fake it. Be detached and calm. They need that. After they go through their branching decision tree questions for the type of emergency we're talking about, then they will want you to fill in more detail. Please be sure to note for them any dangers awaiting the responders beyond the obvious one, the one that you've reported. There may be dangerous aspects within the danger. Is there more than one threat or risk in play here? We should initially state only what we know. We can then get down to anything else. That may be things you've heard, and you can give a guesstimate of the accuracy and credibility of your source, but you only report what you know, what you've seen and done. All these nuances are what makes a live cell call better, or better yet, a landline call better. But when it's too dangerous to speak aloud, you can text to 911. The address is literally, the phone number is 911, of course. Try to determine as you're dialing what and where, so you can keep it very brief. You can send only text, pictures, things do not work, and you can send it only to 911. You can contact other people after you've done this, but it only goes to 911 in this instance. And while we're talking about your phone, please commit now or get out your phone now and sign up for Arlington alerts or your alert in your district in the NCR or elsewhere. I notice we have some commendably far away attendees. Commit to getting that into your phone as something you want to receive. You can pick what kind of data you can get. You can pick how it's sent to you and how you receive it. But it's really important. The alerts save lives.
Enough said. When police arrive, remain calm, of course. Hands, again, empty and raised. Do not put your cell phone in your hand. It's a easily palmed small black object. That could be your other gun. This could be your ankle gun. Nothing in your hand. The first wave of law enforcement you will see, likely heavily tactical mode, are not there to rescue you. They are there to neutralize the shooter. As soon as they're sure about who you are in the room or space where you are, they will go on by. Don't be insulted. They need to quench the danger. When they come back to you or when the second team gets to you, do only what you're told, please, and only when you're told to do it. Don't anticipate, watch them carefully and obey what they say. Their protocols are that everyone may not be a victim. One of the easiest ways to get away with these things is like the Parkland shooter. Just fold yourself into the evacuees and leave the scene. And they cannot turn their backs toward anyone they don't know. Who you are will be determined outside and in effect under guard. Don't take it personally. Now, in the first or second wave, there may be tactical TECC medics who can drop off the suite. They'll then ask you to debrief on your patient. When they or EMTs get to your patient, be prepared, please, to brief on with the EMTs on the next slide here on patient injuries, your treatment of them, and the patient's response. Point out, please, chest wounds. This is all obvious to you. They have a lot to take in and they have to reprioritize. Point out chest wounds, tourniquets, wound packing. Note for them, please, with as much precision as you can, changes in the mental status that Catherine went over. How have their alertness and responsiveness been, and how have they changed? Those are important indicators for them. You have now been the help until the help arrived. It's here. You have made the difference that you're training for now, and in your additional training, CPR and other kinds of first aid. Next, Catherine will lead us in applying some of the scenario for practice.
Okay, guys, we're just going to run through a quick scenario. As Paul said earlier, it's important that you review concepts and you think through things that you would do if certain things happen. And your brain really doesn't know the difference between something you've done and something that you've imagined you've done. So it's an interesting tool you can use to kind of think through a scenario and then remember the skills we've talked about. So let's do that tonight. We're going to use an everyday scenario. So this is not a mass casualty event. You are leaving your home and you step out to go for a nice walk in your neighborhood. When you see your neighbor and he's down on the ground, he has a running chainsaw next to him. A ladder has been knocked over and there are tree limbs all around. He has a heavily bleeding gash in his upper leg. He looks sweaty and confused. Now, before we talk about what we can do for your neighbor, let's take a step back and let's remember SCAB-E, okay? Because before we treat, we have to think about treating the worst first, and we have to consider our situation, right? So what do you guys think? Take a step back, you're looking at the scenario. What are some of the first things you're thinking about? Turning off the chainsaw. Yes. All right. Yep. You're going to look around, make sure that you're not in any danger of a falling limb, or make sure he didn't hit a power line. Yep. Scene safety. Really good job, guys. Situation. Are you safe to begin treating? So let's assume you've turned off the chainsaw. You're in your neighborhood. This isn't a mass casualty event. Before you start thinking about treating, you see that heavily bleeding wound. What's another thing that you might want to think about doing to make sure that yes, exactly. There you go, Bill. Dialing 911, PPE, fantastic. That's right. That's right. Good job, you guys. 911. All right, let's move into treatment. Okay. We've looked at the situation. We've got help on the way. He has a heavily bleeding wound in his upper leg. He's confused and disoriented, and his jacket's ripped up too. But you don't see any blood. What do we do next, guys? Right. Something to stop the bleeding. So you're right outside your house. Do you have anything? Yeah. Pack and treat for shock. Stop the bleed by direct pressure. The first thing we always do is immediately hold direct pressure on a bleeding wound. Remember, if nothing else, that's the first thing that's got to come to your head. All right. Good job. Does anybody have a tourniquet? I'm just wondering. Yeah. First aid pack by the front door. Okay. So somebody's thinking about, yes, somebody does.
Is the patient awake, Catherine?
Yep. Yes, the patient is awake. He's confused and disoriented. He looks a little panicky. Calling in for help. Yes. Tourniquet in the pack. Okay. So let's assume that you have applied that tourniquet and the bleeding has stopped. And guys, help is on the way, but you're noticing that whereas he had been talking to you in full sentences, now his speech is coming in 1 and 2 word gasps. And he really seems to be getting more and more confused. You're looking at his jacket and you notice that there is a hole punched through in the back, and you see a light bit of bleeding. He might have hit a limb on the way down, guys. So what are you going to do? Yep, you're right. He might be going into shock, guys. Good job, Lanny. You're thinking, yep, remove clothing, Penelope. Good. Yep, chest seal, Paul. That's good. If you have one, you're going to use it. Look for the holes and cover them, right? Checking for other wounds. Yeah, when things start to go poorly, you're seeing a decrease in level of consciousness, or you're seeing, breathing changes. There's something else going on. So you guys are really thinking about it. Check for all the holes. That's right. Good job. Yep, exactly. If it's cold, even if it's not cold, he's losing body heat, right? So you're getting him off the ground. You're treating for shock. So guys, what are some of the things that we do to treat for shock and hypothermia? Quick head to toe, that's right. What can you do to help him? Keep him warm. Perfect. Cover, isolate from the ground. Perfect. Maintain the body temperature. Excellent, excellent. All right, reassure him, Daphne. That is great, because remember, psychological first aid, he was panicky. He's scared. He knows he doesn't feel right. He knows he's got a really bad wound. So what are some of the things that you can do? The 911 operator told you that they are 3 minutes away at this point. Yep. Ask him if his family's home. Try to make that connection. Really good stuff, Carol. Good job. Bill, that's a fantastic idea. We didn't cover it tonight, but elevating the leg, especially the bleeding leg, is not a bad idea if you can tolerate it. Stay with him. Joseph, good answer. Help is on the way. Reassure him. That's right. I'm going to stay with you. I'm going to be right here with you until they get here. Fantastic. Fantastic. Okay, guys, we have put this together. You've thought through the scenario. Hopefully you saw it in your head. And that's what I wanted you to do. I wanted you to just think about it. You've learned a lot of things. And thinking about what things to use, when to use them, what your situation is, what order to do things. That's all stuff that gets easier and easier and easier with practice. You guys really did a fantastic job. Yes, you're right, Andrea, keeping him conscious and keeping him engaged with you until help gets there. So hopefully we've given you some skills or helped you brush up some skills that you had in CERT Basic, and hopefully you're putting it all together. So if you're ever in an emergency, you will feel yourself better able to use them and jump in as an active bystander. We really do appreciate your spending time with us tonight. All of our instructors are with Arlington CERT. If you would like to make any comments or reach out to us, please consider contacting us. If you are in Arlington and you're interested in UHA or volunteering, please consider volunteering more. We're definitely always have activations. we always say when you come away from a course like this, we really encourage you to take action. So just something, make a promise to yourself that you're going to take action in some way. We have a particular focus on really treating the 4 killers. So if you think that Until Help Arrives training could be helpful to friends, family, any groups or people that you work with, please let us know. Or lots of, somebody locally to you might teach UHA. So just reach out. We're always happy to help. Think about that practicing, looking for the TECC kits. Really think about that now before there's an emergency. You may want to be an advocate. You may want to ask for bleeding control kits to be installed where you work or where your kids go to school or where you all play or where you shop. It's not a bad time to do it, especially before you need it. There are a lot of different other trainings you could consider, like CPR, AED training. Please stay up with that. It's really important for the everyday emergency. First aid training. There are a lot of different ways that we can take action to serve the community. So we've reached the end of the presentation. You guys are a fantastic group. We definitely want to open it up for any questions. And yes.
Catherine, someone was wondering if we could do the tourniquet demonstration again.
Yeah. Oh yeah, absolutely. So if it's all right, I really need to stop sharing. I'm the crazy looking at this thing is all I can see. So now hopefully you can see me. All right.
Can everyone see Catherine large now?
You guys see me okay? So again, this is a SAM XT. And buckle. Okay, buckle. The strap goes through the hole like this. Okay. Not like this, but like this, where this hole is. All right. High and tight, guys. High and tight. My suggestion is always orient the ratchet to the outside of the body so you don't jostle it. You're gonna, I'm gonna pull until you hear a click, okay? Let's see, do you hear it? Hopefully so. All right, you would tighten it until you can't tighten it anymore. And then after you can't tighten it anymore and bleeding has stopped, then you're going to put the ratchet into the catchment device, which is right here. Okay. And you're going to put a strap over it. And you're going to put the time you applied it. If you don't have a strap like that, write it on the arm, write it on a piece of duct tape. As someone said in chat, duct tape has a lot of great uses. It's a great thing to use. Put it on their shirt, somewhere where people will see it. And then always make sure you're going to always tack your loose ends down, okay? Because you don't want anything to come loose. And that helps keep it secure. Never loosen it. That's something that doctors or medical professionals will do. If you're in the Arlington area or nearby, Fairfax, Alexandria, anywhere in this capital region, we do invite you to come to our outdoor skills practice. It might be something you've done a while ago and maybe you just want to brush up on it. But we will have all kinds of different types of tourniquets there. We'll teach you how to do improvised tourniquets in person. We'll work with you one-on-one to make sure you feel really comfortable in the skill set. Every technique we talked about here, with the exception of the body lifts, and we might do that next time. We'll go over this with you one-on-one until you feel really confident and really competent walking away, applying those skills. So we do invite you. And I think Janine might have posted a link. But if not, it's available on our webpage with Arlington County. And we're so grateful that we as CERTs got to be with other CERTs tonight. This is a true delight for us. It's a real pleasure.
One comment that somebody made is after we were talking about wound packing, that they use duct tape. Now, duct tape would hold it on. It's not going to be quite as tight as if you're using one of the ACE bandages. If you tighten it a little bit more.
Yeah, because it doesn't have the stretch retract feature.
Right,
yeah, right. But I mean, to the point, duct tape is amazing. And it can be used in many, many ways. And, you use what you've got. So part of this class is to teach you like sort of what it looks like. But, you have to work with the materials that you have at hand. And if you've got duct tape for your tie down or you've got duct tape to secure something, by all means use it. In a tough mass casualty event, nothing is going to be perfect. So.
As females, we can carry duct tape.
If you have to use duct tape, braid it at the end and make the X for pressure.
get a
Yeah.
little.
Oh, that's a great idea. And thanks for sharing that, Douglas. That's really great. Yeah, you can do that. Again, it's a delight to be with you. We are on time. We're at 9 o'clock. So the instructors will stay on for a little bit just because we'll do a quick debrief. But we do want to say goodnight to you all. If anybody has any questions, please feel free to unmute or just speak up now because we're about ready to close out.
Yeah, I'll give the closing and then they can ask some questions. Well, thank you for participating in CERTCON 2021, the virtual conference where we celebrate you, the everyday CERT. Thank you very much.
Thank you, Marco.
Great presentation. Thank you all.
Thank you.
Thank you, everyone.
We hope to see everyone in person soon. Really
Thank
do.
you.
Thank you very much.
Thank you, guys. And this is Boston Calling, and we're going to be starting our new CERT program after 20 years. So I will definitely be reaching out to you guys.
Please do. We'd be delighted to help in any way. Well done.
We're going to bring you up virtually. That's what we're going to do.
All right. All right.
Thank you.